Good evening, everybody. Am I audible?
Good evening, doctor.
So,
Good evening.
good evening, Dr. Karan, Dr. Kirtana. Are we good to start, or we could wait for a few more participants?
You turn on my video, it's not good.
Maybe we can wait another 1 or 2 minutes and then start off and let others join.
Yeah, sure. Sounds still it's echoing.
Your voice is echoing, Dr. Karan. Incidentally, my laptop is acting up and I have to join from my phone. So if there are any, disturbances, please let me know.
Okay.
And in case I have to break off or something, I'm sure Sumana will be able to take over.
Yeah, that's fine. It's echoing.
Dr. Karan, your voice is echoing.
I know. That's why I'm
The
checking.
audio on there.
Sure, please.
What is audio?
Maybe that we need.
Dr. Karan, now you can just speak once and we'll check. Yeah, your video is great, Dr. Karan. If you could just speak and we'll check
I'm speaking. I'm just.
There's still some sort of reverb that is there,
Hello? Can you hear me?
Yeah, this sounds good. Yeah, this is fine.
I can't hear her now.
Mic check again, please.
I can't hear her now.
You turn up your.
Hello, mic check.
ये mute हो गया अभी.
नहीं volume ज़्यादा कर.
I can't hear madam.
I'm speaking now. Am I audible?
Function volume.
Yes.
Function volume. My function volumes.
Can you say something, ma'am?
Yes, am I audible now?
No, she's talking. You can't hear her.
I'm saying something, yes. Sushant, am I audible to others? Audience, am I
100%
audible? Please, can you
No,
just
Sharmi,
let
she
us know
went
in the chat box?
off.
Yes, doctor, you're audible.
Great. I don't have much to speak. It is mainly, Dr. Karan and his team. So it's okay if I'm not being heard.
You're audible, doctor.
Great. So since we are 15 minutes up, and for the benefit of those who have joined on time, maybe we should just be starting off the session.
Yes,
Could I request Sumana to just start off with a brief introduction of GHA, and then I would be honored to introduce our two speakers for today. Sumana, you're there?
Yes, doctor. I'll be starting with the introduction.
Sure, please, let's proceed.
Yes, good evening, everyone. I truly welcome everyone to today's webinar. Introducing you all to GHA. GHA is India's leading med-tech institution. Our mission is to cultivate skilled and empathetic professionals to meet the healthcare sector's evolving needs. We harness the power of technology to enhance every aspect of learning. At GHA, we focus on bridging the gap between traditional education and dynamic demands of the healthcare industry through our 5 distinct academic verticals. We are honored to have Dr. Jayashree Bhatt as academic director. Welcome, doctor.
Good evening, everyone. Thanks for that.
Yes. Dr. Jayashree is a renowned ophthalmologist with over 20 years of experience. In addition to her clinical work, Dr. Jayashree has a keen interest in aesthetics and cosmetology. She also serves as the academic director of GHA for the Ophthal Vertical, where she guides and inspires the next generation of healthcare professionals. Thank you so much, doctor. Now over to you.
Thank you, everybody. And most welcome to all our participants who are here and waiting eagerly to listen to our experts. So without much ado, let me go ahead and introduce our today's speakers to you. We have with us Dr. Karan Shetty and his associate Dr. Kirtana. Welcome, Dr. Karan Shetty, Dr. Kirtana. Very glad to have you all here. Dr. Karan Shetty has completed his MCH in plastic surgery, and he's a board certified plastic, aesthetic, and reconstructive surgeon specialized in aesthetic surgery. His focus is on rhinoplasty, facial rejuvenation, body contouring, and breast aesthetics. He's trained in super microsurgery at the University of Tokyo and advanced rhinoplasty in Germany. And he also has trained in breast aesthetics and body contouring in University Hospital Moncloa in Madrid under Dr. George. Also, he is the co-founder of the NGO Anti-Pollution Drive to promote environmental cleanliness. Now, this is something trivia which I did not know. Honored to have you here with us, Dr. Karan. And it's also my pleasure to introduce to everybody over here our associate, Dr. Kirtana. So Dr. Kirtana, she's a gold medalist plastic surgeon trained at Bangalore Medical College. She specializes in aesthetic surgeries like liposuction, body contouring, rhinoplasty, etc., and reconstructive surgeries of like trauma, burns, and cancer. She's completed her MS from Osmania Medical College and received the ICRETT Fellowship for Breast Surgery at MD Anderson Cancer Center, USA. Collectively, Dr. Kirtana has 10 years of experience as a plastic surgeon. So a grand welcome to both our honored speakers over here. And I hand over the webinar to you now to deliver your expert talk to us. Thank you.
Thank you, madam. Thank you, GHA, for introducing us and for getting us on board, both me and Dr. Kirtana. It's an honor for us to be here. It's an honor for us to start our educational or teaching journey with a med edtech platform like GHA, Global Health Academy. It is not only with endeavors like this, it is not only the students that are learning, we ourselves learn from these kind of courses. The best way of learning is also by teaching. So we are very excited to be here. We are very excited to start this journey with GHA, and I hope this lasts for a long time. So having said that, today's session will be an interactive session with both me and Dr. Kirtana kind of dueling it out and discussing the different problems that happen during a person who comes with facial trauma. So this is mainly for MBBS doctors, BDS doctors, or anyone who is dealing with like a casualty or an emergency setup. This can be in a village, this can be in a tertiary or quaternary center in a metro. It can be simple things for you to look out even at home. So hopefully this encompasses the basics of what facial trauma entails. This can be your old parents who fall down in the washroom. It can be, this will give you an idea about how to assess, and it will give the doctors who are working in the emergency room a clear idea of a step-by-step evaluation of how to deal with facial trauma. So once a person, say, comes to the emergency, we do an initial evaluation. So this is where I'm going to get Dr. Kirtana in. So Dr. Kirtana, what are we going to do initially when a patient comes to us?
So when a patient comes in with a very apparent facial trauma, we shouldn't get too carried away with that, but first remember the basics of trauma assessment, because there might be a much more serious injury that we are missing just because the face is so clearly injured. So ABCs of initial trauma assessment is something which all doctors are familiar with and have have to do it as a first step in any case of trauma. That is your airway, breathing, and circulation. There's no way we can miss that. Mostly bad facial injuries are part of a polytrauma. Generally, they are bad RTAs where the
Yes.
patient has not worn a helmet. So they also they can have a head injury, they can have chest injuries, intra-abdominal injuries. So first and foremost, a complete evaluation or a primary survey of the body is essential for the casualty doctor to do. Once we rule out other more serious injuries, we are sure there's no chest or abdominal injury or no serious head injury, then we go on to assessing the facial injury. So if you look at it systematically, first when you inspect the patient, if there is an open laceration or an abrasion, it is clear. There is no need to explain on that. But subtle changes, suppose there is a closed fracture, there's a mandibular fracture, but there is no external injury at all. Then there is a subtle asymmetry that you will notice in the face. So facial symmetry is something you should expressly look for. Sometimes it can be masked by edema, but it's something we have to learn to appreciate. And then after inspection, we go about palpation in a systematic manner, starting with the skull, the supraorbital rims, the infraorbital rims, the zygomatic arches, the nasal bones, the maxilla, and the mandible. So this will give us an idea about any facial fractures if they are there. Then main important things are you check the eyes, test on the visual acuity, and quickly look for diplopia and extraocular movements. In the ears, generally, closed injuries can have hematomas, which if missed can lead to a lot of complications in the future and should not be missed. And in the nose, generally, sometimes there is a gross deviation obvious, but a proper nose examination needs a nasal speculum, good lighting, and ideally some suction, with which we can examine the internal nose, look at the septum, whether it is displaced, buckled, if there's a septal hematoma, which will look like a bluish boggy swelling on the septum. So also coming to the neck, go to the next slide. The neck is an important structure which a small cut on the neck, a deeper injury on the neck can look inconspicuously small. So as we know, all the vital structures, the nerves and the vessels are in the neck. Hence, even small cuts on the neck should not be, taken as simple lacerations and should be thoroughly examined if they are deeper. Coming to the cheek, the two main things we need to look out for are the facial nerve and the parotid duct, which could be injured. So if you look at a line drawn from the tragus to the philtrum, the middle third of the line is where the parotid duct is there. And if there is there's a deep laceration traversing that area, it can have injured the parotid duct. Facial nerve, of course, you check for all the facial nerve functions, which could be deviation of the angle of the mouth. When you ask the patient to show their teeth, you ask the patient to puff up their cheeks and check if the power is equal on both sides, eye closing and forehead movements. So this is the basic facial examination, which in a polytrauma patient, it has to be done pretty quickly. In 5 to 6 minutes as a routine, we have to learn to check all these things and not miss out on anything.
Yes. So I think she's done a great job on it, explaining how an examination to be done. To kind of summarize, as soon as the patient comes, take their clothes off, assess them completely, make sure that the rest of the body, do they have fractures on the legs, on the arms, is there a penetrating injury into the chest, abdomen, make sure all those things are there, not there, evaluate, look at the face. When she spoke about the ABCs, the face is very important, primarily because breathing is a part of it. A lot of times you can have an injury in the mouth, which means an injury in the fracture in the mouth. You can have teeth which are missing, which you can have blood which will trickle into the throat, and because of all this, they can have associated head injury as well, because of which they might not be completely conscious, and they can aspirate because of that because of blood going into this. So it's very important for you to quickly kind of understand what is to be done. You wear a glove, check from top to bottom, see for facial symmetry. Like Dr. Kirtana said, look at each part of the face. It has to be done quickly because you don't have too much time. Suppose now there is the tongue is falling back, or if there is blood trickling, you have to suction into the mouth. If the patient requires intubation, you have to intubate quickly. If the patient is able to breathe on their own, kind of make sure that you start some oxygen, you start an IV line, you start basic fluids, and then you kind of make sure that all these things which are there, as Dr. Kirtana said, are assessed properly. And I think she's spoken about each and everything. In the neck, one more thing was the penetrating injury of the platysma, as we have mentioned here. It basically, we have seen a lot of people with penetrating or stab wounds into the neck. It looks like a very small wound, but then when you open it, because it is a neck wound or a penetrating wound, it have gone hit the major vessels. So anything in the neck has to be taken very seriously, even if it is small, thin injury. We have to make sure sometimes that we explore it and see if this one, because if the hematoma starts getting bigger, then it can be a problem with breathing. So it is very important that we see a top to bottom evaluation of the face. And if each particular point that Dr. Kirtana has spoken about is seen as a routine, if you can write down in your casualty or in your wherever you're working or in a primary health center, if you can write down these things, put it on the emergency board, and then as you start getting used to it, say you do it about 5 to 10 times, then by the 10th time, you don't need to look at the paper. It will just come to you as second nature. So this is very important because all these things are life or death situations, and it's very important to take them very seriously. So let's go to the next slide. Anything else you want to add in this? Yeah. So you kind of now have evaluated the patient. So now we have to, when Dr. Kirtana was talking about facial symmetry, asymmetry, it means, and we look at occlusion. Occlusion means how the upper jaw sits on the lower jaw, or the teeth sit on the lower teeth in a normal way. If the occlusion is not correct, most probably there's a fracture of the face. If the vision, if there is double vision, if there is inability to move the muscles of the eye, there could be a fracture in the orbital region. So these are very important things for you to analyze. And the best way of analyzing, now we have diagnostics, which are excellent. So once the patient is stabilized, you do a 3D CT scan of the face, see what is fractured, what has to be corrected. So always start with the bone first and then come outwards. So you have assessed the rest of the soft tissue, the main important structures like the facial nerve, the parotid duct, the eyes, the lips, competence of the lips, and then finally you come to the fracture itself. So now you assess and see if there is a fracture. Then definitely if it is a fracture which is displaced and is causing a functional deformity. A functional deformity is vision, is occlusion, or inherent cosmetic deformity, like one side of the cheek is completely flat, which if not corrected, will make the symmetry of the face completely different, and it's more difficult to correct it later. So these are the reasons why a diagnostic study like this is very important. If it is a primary health center, the least you can do is get an X-ray done of the face, and you can take it from there. Anything else you want to add on this?
So I think CT scans have superseded X-rays now.
Yes.
Facial X-rays are not that helpful when it comes to deciding whether
Right.
patient needs surgical management or not. So to get to that decision, we definitely need a CT scan.
Yes,
Yeah.
absolutely. So let's go to the next slide. Yeah. So what do you think are like now we know what is the problem. We know that there could be a fracture. If there is a fracture, we fix the fracture with plates and screws in different parts of the face and make sure you bring it back to a pre-injury state. So what do you think are the general principles? Now you have the patient has come to you. What do you think you need to do to kind of get the patient's face back to what it was before the injury?
So I think our job as a plastic surgeon is to restore the patient's face as much as possible to how it was pre-injury. The appearance as well as the function. That's what we focus on. To achieve this, there are certain general principles that we follow in the face as such. So the first and foremost, if coming to the surgical principles that we follow, in RTA, there is a lot of dust, particulate matter that will be embedded in the wounds. Abrasions are very common in the face, especially when the patient falls on the road when they are on a vehicle because of the motion, because they decelerate very quickly. So these abrasions can have a lot of mud and particulate matter, which if left like that, can lead to permanent tattooing. So these particles are embedded in the dermis, and then when the epidermis grows over it, the particles remain permanently there. And it's very difficult to get rid of this once the wound has healed. Hence, it is very important that even simple abrasions on the face should be thoroughly debrided, ideally under general anesthesia. We generally do not advocate doing any of this under local, because if the abrasions are extensive, it is very painful for the patient to go through this debridement procedure, and even we as surgeons won't be able to do a thorough job. So ideally, under proper general anesthesia, if you can see the picture on the screen, in a case like this, the ideal treatment would be take the patient under GA and thoroughly scrub the wounds. Scrub it to, under magnification, we scrub it to the extent where all the particulate matter is gone. And that is why you see the result where, the skin is almost looking as normal as it was before. So one is this thorough irrigation and debridement. When it comes to sharp debridement, suppose there is a wound on the lower limb, the principles are different there. We debride all the dead tissue that is present. But when it comes to face, we have to change our plan a little bit, because most of the structures on the face are not replaceable. On the leg, you can replace it with the muscle, you can put a skin graft. But on the face, there is very little loss of tissue that you can, afford. So especially when it comes to eyebrows, lips, it is better to debride as less as possible. Even if you feel that the skin doesn't have a wide pedicle, it has a very small pedicle, it may not survive. It is better to leave it for now and just give it a chance to perfuse. So one property of the face is that it has very, very rich and robust vascularity, which helps a lot in good healing. We see surprisingly good healing in even bad facial wounds, and even the chance of infection is very, very less. Especially when in the first stage we have taken, the due steps of giving a thorough irrigation, then the chance of infection are really negligible. So the debridement has to be based on the area. You have to be careful not to debride too much also. Also, there are RSTLs, which are resting skin tension lines, which are basically lines along which if you place a scar, the scar will be least visible. So there is nothing called a scarless surgery or a scarless treatment. The truth is there will always be a scar when there is a cut on the skin. But how well the scar heals depends on the location of the scar, as well as how well the tissue has been handled while closing the scar or closing a wound. So whenever possible, it is difficult in case of injuries, because the injury is already there. But when given a chance, if we have to extend an incision, or if we have a chance to close a laceration in two different orientations, we must select one which goes along the RSTLs of the face. Also, cautery should be used at very low settings in the face, not at the same settings as you use for other parts of the body. And ideally, bipolar coagulation is preferable over the face, because it has less collateral spread of the heat. Also, as I said, a lot of RTAs have embedded plant particles and all that. So there should be a proper search for foreign material. Again, this is possible only if the patient is under proper anesthesia. Otherwise, we cannot do a complete job.
Yes.
Yeah.
Yes.
So
A lot of times, I think people try to do a lot of these procedures under local anesthesia,
exactly, yeah.
which limits the kind of result you get after the procedure. Usually, the face is one of those places, because of the high vascularity of that area, is quite forgiving if you
Mm.
treat the face well. If you can see in this photo as well, initially when she came, she was quite bad, but then the recovery is almost complete to its, which means the face forgives in terms of this one. So if you follow these things, RSTL, like Dr. Kirtana said, those are lines which are naturally there on your face. If you see older patients, you'll see lines, straight horizontal lines on their face, lines here, lines. So those are natural lines which are there on the face. So if you follow these things that have been explained, I think at least you should be able to get a decent result with any kind of trauma. Remember, the face is relatively forgiving, so don't try and cut and remove too much. All right, let's go to the next slide. So we are going to be talking about how each injury should be treated. So we have simple lacerations, you have complex lacerations, you have avulsion, and you have secondary intent, healing by secondary intention. Simple lacerations, what do you mean by simple lacerations?
So simple laceration is one where it could be a straight cut with where the edges can be opposed to each other cleanly, where the edges of the cut are clean and it's not a stellate or an irregular injury, and also when there is no tissue loss. So in these wounds, I think apart from what I spoke about earlier, suture selection in the face is very important. I think a lot of the result depends on what kind of suture we are selecting for the face. I think in our practice, we get referred patients who have been sutured with, say, 2-0 silk or 3-0 silk on the face
Absolutely.
somewhere, and they comes to us saying, we want something better. We have redone a lot of lacerations on the face. So I think it's just a matter of, knowledge, knowing that, okay, on the face, we should use a different set of sutures. So one thing that's important in a simple laceration on the face is layered closure. Generally, you almost never close only the skin. So the secret to a good scar is proper layered closure, where the tension of this scar has to be taken by the dermis, not by the epidermis. So the sutures that go through your deep dermis is the most important layer. They need to be inverted and they need to be strong. So the ideal suture, I think, would be PDS, which we use in our practice, but it may not be very widely available. If it's not available, you could go for Vicryl.
Yes.
But PDS, because it's long lasting, it prevents stretching of the scar. So use smaller sized sutures, probably 4-0 or 5-0, PDS or Vicryl for the deep dermal sutures. And then the dermal suture should be in such a way that the skin edges are approximating and there's no further gap. And then you put your epidermal sutures using either 6-0, at least a 6-0, or even if you can, 7-0 or 8-0 also can be put on the face. So the choice of sutures, as I said, makes a huge difference to the
Absolutely.
scars.
Smaller the sutures are,
Yeah,
the better the scar it is. Distribute the tension in different layers of the injury, so that each layer takes up the tension, and then in the end you are left with almost nothing to close.
Correct.
So these are to do with simple lacerations, and most of the time, if it is a simple injury, which means an injury to do with home-based, to do with any kind of simpler forms of injury, only thing we will see is a simple laceration. Then when we talk about complex lacerations are seen more in terms of road traffic accidents, in people, maybe low velocity road traffic accidents, where they decide that, I'll go from point A to point B just to pick up some groceries, and they don't put their helmets, and they go in and they have these kind of injuries where it is low velocity and hence doesn't cause major fractures or major injuries to the body, but results in complex lacerations of the face where there is either a loss of tissue or an injury or a cut which is irregular. Like Dr. Kirtana said, a simple laceration is probably a straight line. A complex laceration is something which is irregular, which is cut in a way that might have some loss of tissue. So how do you think we can deal with complex lacerations?
So complex lacerations, surprisingly, when you look at them first, it looks like there could be a lot of loss of tissue. But
Yes.
we notice that once you give
Clean
a
it.
wash and clean it, you see that most of the fragments are there. So repairing complex lacerations is something plastic surgeons really take it as a challenge. It's something because it's like solving a jigsaw puzzle
Absolutely.
on the face. So there are multiple fragments, and you really have to take some time to decide what goes where. And if you have some practice and you're patient, you will be able to fit in the pieces where they fit. And then you follow the same suturing technique. I think in complex lacerations, what you need to look out for is loss of tissue. If there is a loss, then you will definitely need a plastic surgeon's help on how to replace it, whether you need a local flap or whatever. But most of the times, even something that looks like there could be a tissue loss, most of the time there is not on the face.
Yes.
And
So
we
do you
will
think
be able to put the pieces together.
do you think a complex laceration, like you said, a jigsaw puzzle, but do you
Mm.
think if it is just irregular, you
Mm.
can cut a little bit and make it a simple laceration? Okay. So different times you need different approaches.
Mm.
Can we go back to the previous slide? Okay. So so different types of lacerations require different. An avulsion injury. Next is an avulsion. Avulsion means where the tissue is taken off from a particular part of the face, and it is hanging just on probably one axis. Usually when there is an injury, an avulsion injury, which means three sides are cut and it's probably hanging on just by one side. On the face, because of the excellent blood supply of the face, we usually do not recommend kind of cutting that till you see extremely good perfusion. Like in the rest of the body, you kind of use that flap itself or the avulsion injury itself, slightly freshen it and kind of put it back in its place, and then kind of wait to see how well it heals in the post-operative period. More times than not, it kind of heals perfectly in that position. Very few times you'll see that the edge of the kind of injury is kind of becomes dark or necrosed. And then the final thing is healing by secondary intention. Which are the areas you think can heal by secondary intention?
So there are certain areas which are better left with the injury is small. They really heal well by secondary intention. Second intention is basically where you're not suturing the wound. You're just washing it and leaving it open and allowing it to contract and heal on its own. So generally we see that concave surfaces heal well that way. But certain convex surfaces like say the bridge of the nose, there if you leave a wound open, it stretches out a lot. So what you need to understand is when there's a convex surface, the edges of the wound tend to stretch out a lot. And how good a secondary intention healing scar looks is by how well it contracts. So if it's a concave surface, the contraction is much more effective and the scar becomes less conspicuous. So yeah, there are certain areas where we take a call that leaving it alone would give a better result than putting sutures in it.
Absolutely. Especially on the nose, you see these bad scars that come to us. It is primarily because of the convexity of the.
yes.
We were actually discussing it the other day. Sometimes if they have a hump, maybe you reduce the hump and then the scar kind of improves, shrinks and improves. So I think this is like a general principle on how to handle each kind of injury. Remember, if they are very small, yes, you can do it under local anesthesia. But if it is slightly bigger, try to get an anesthetist involved and try to do as much of these things in the operation theater, because then you have good light, you have good access to instruments, you have good access to sutures, you have a nurse around. So these are just improving your comfort level of the surgeon improves the result of the patient. So remember, the person who is doing the suturing or the correction of the thing has to be very comfortable. When they are comfortable, the results speak. And I think most of our results, as you can see in this picture as well, the results get better over a period of time because of meticulous suturing and because we usually do it in the operation theater. All right, let's go to the next slide. All right, let's talk about the scalp. Scalp is an often under looked. There's a lot of focus on the face, but what happens in the scalp? What do you start looking for in the scalp?
First thing would be, of course, ruling out any fractures of the skull. And once that is done, main thing that we notice in scalp lacerations are that they bleed a lot. They bleed extensively because the blood vessels are tightly adherent to the fibrous tissue. Hence, they do not retract at all. So you can have a good amount of blood loss very quickly when there's an extensive scalp laceration. So many times in the emergency, we just take an enma suture in the scalp to just stop the bleeding. Other than that, of course, cosmesis is not as important as in the face. I think mainly what we need to concentrate in the scalp is avoiding alopecia along the scar line, which is again a combination of things. If you use a lot of cautery, electrocautery on the edges of the wound because it is bleeding, then you are going to damage all the hair follicles along that. And eventually patient will end up with scar alopecia, meaning there is no hair growing on that scalp, which is really bothersome to patients. So if you are a little bit careful and avoid using high levels of monopolar cautery, try to apply pressure or use suture ligation of the bigger vessels, then you can largely avoid scalp alopecia. I think from our point of view, that would be important. Also, when it comes in the scalp, it is common to have large wounds which do not close primarily. There's not much elasticity. So often flap covers are needed on the scalp where we use rotation flaps or transposition flaps and mobilize adjacent scalp to close wounds. Another interesting thing is total scalp avulsion, which can happen when somebody's hair gets entangled in a machine or a fan, which can actually rip off the entire scalp. If this happens, there is only one way of treating it, and that is by microsurgery, where the scalp has to be replanted. The vessels of the scalp have to be reattached to vessels of the face. It is a complex procedure, but if you come across such a case, then you have to immediately refer the patient to a center where microsurgical facilities are available. Time is very, very important because the ischemia time, as it becomes longer, the success of the surgery becomes lesser. So a very quick referral would be important, and also preserving the scalp that is avulsed properly. It should not be put directly on ice. It has to be wrapped in a gauze or a cloth, and that has to be placed in a bag with ice cubes. So the tissue as such is not directly in contact with the ice, but it is covered by another layer which is kept cold. So this is how it has to be transferred.
Excellent. So I think in scalp injuries, what we usually see is because of the amount of blood loss, most of the even the calls that we get, either from the duty doctors or from the nurses, is that they suddenly get very scared of these kind of wounds, whereas facial wounds don't bleed as much as a scalp wound. Like Dr. Kirtana spoke, the vessels don't retract. And so most of the calls are because people are scared. because they think that something is going to happen. So remember to keep your cool, and you can take, since cosmesis is not a big importance here, so you can just take continuous sutures, including all the layers, as she said, en masse. So yes, that is to do with the scalp. Let's go to the next slide. All right, as you see, eyebrows. So we are now going to be talking about specific areas of the face, primarily because a lot of them have to do with landmarks. What is the landmark of the eyebrow? It is the fact that there is continuity of hair and there is a shape to the eyebrow, which is why it is very important. Now, if an injury like this, as you see in this picture, if you do not suture it according to the shape of the eyebrow, you can have one side up and one side down. So what do you think are the important things for us to look at when we talk about incisions or injuries in the eyebrows?
So yeah, eyebrows are a very, very important part of the face. Even a very small change in the alignment of the eyebrow can be quickly caught by the eye. So in the eyebrow, mainly remember not to debride tissue as much as it's better to leave everything as it is, because even a small loss can look very conspicuous later. I think the major factor would be alignment of the hairline. So the superior and inferior brow line, if you can get that alignment correct, and if you can get the hair alignment correct. The hair in the eyebrow, the orientations are different from medial to lateral. The direction of hair also changes, if you notice. So that direction also has to be maintained, and mainly the level of the eyebrow, the hair should be very, very exact. Even a millimeter difference can be very obvious. So an easy way to do this is to take your first stitch at the hairline on both sides. So take a stay, don't tie it, take it and just keep it like that. And then you repair everything else, so that finally the alignment comes out correct. If you start suturing from inside and leave this for the end, you will end up with a misalignment and you won't be able to get an alignment at that point. So, and also, as I said, don't debride much. So if there's a small area where there is no skin, it is better to just leave it as it is. Secondary healing works very well for the eyebrow. They form really good scars which shrink well. And some patients do come back with scar alopecia, and they can be helped with scar revisions or with hair transplantation at a later date.
Yes, absolutely. If there is a scar which remains, and if there is a loss of hair in that area, a lot of times we can just do a hair transplant in that particular scar itself and improve the continuity of the scar. These are all very important areas, because like Dr. Kirtana said, it is very easy for the eye to see something off about the face. Even if you miss a tooth, your eyebrow is cut, your eyelids have some difference. It's very easy for the eye to this, and most often than not, people ask you about it. What happened to the eyebrows, and that takes them back to the injury and accident itself. So giving a very good aesthetic result in these particular parts of the face not only prevents them from future trauma of people repeatedly asking them the same thing again, what happened to your face, what happened to your face, but also helps them in early recovery and getting back to their regular life. So like Dr. Kirtana said, eyebrows, I think, are one of the most important areas in maintaining continuity. Let's go to the next slide. Eyelids. So eyelids are another, so we are coming from up down. So we have done with the eyebrows, the eyelids. The eyelid is very important because, one, it opens the eyelid opens, and only then we can see, or vision is possible only by opening the eyelids. That is true with the upper eyelid. So there are muscles in the upper eyelid which are responsible for these movements. So what opens up the eyelid is the levator palpebrae superioris. What closes the eyelid is the orbicularis. So it's very important for us to see the structures which are normal in the upper eyelid, and to see what has to be done to fix it. So what do you think, Dr. Kirtana, are the important areas that we have to look at when you're talking about the eyelid?
So yeah, firstly, eyelid injuries must be taken very seriously. And the first thing you need to rule out is a globe injury to the globe, because it's very easy for an eyelid injury to penetrate the globe too. And if that happens, and that cannot be missed. So first and foremost, look for any injury to the globe. If that happens, you must immediately get an ophthalmologist involved. If you're sure that the injury is limited only to the eyelids, then so the eyelids have mainly three lamellae. One, the outer part is the skin. Below that is your tarsus, which gives support and shape to the eyelid. And under that is your conjunctiva. So whenever a full thickness injury of the eyelid has to be repaired, it has to be done in 3 layers. You cannot do it in one. So the conjunctiva, tarsus, and the skin have to be closed separately using the suitable suture materials. Also, in eyelids, it is always better to close any kind of injury, because when secondary healing happens on the eyelids, it can cause functional problems later. Something called ectropion, where the lower eyelid cannot completely close the eye on closure, and there is constant corneal exposure. So as a contrast from eyebrows, eyelids must always be closed completely.
So the margins of the eyelid are very important. A lot of times you get vertical injuries on the eyelid, which means, like Dr. Kirtana said, it opens up the entire eye and the globe is seen. So there it's very important, like to form landmarks on the face, like we did with the eyebrow, where we did a superior and inferior suture first, and this. Here as well, you take a suture at the eyelash line or at the point which is the most important landmark, and then you can just turn it inside out, and then you can start closing the inner part and then come out in layers. So it's very important that margins are maintained. It's very important that we make sure that, because this is a part where functionally it causes a big problem. Like Dr. Kirtana said, corneal exposure causes continuous watering. These are one of those injuries which cause a lot of distress to patients, and it's very important to take care of them initially itself, because then to correct injuries like this, you might need a skin graft, you might need a full thickness skin graft, you might need a flap. There are multiple things. So what this causes is more scars. To correct a functional problem, you creating worse aesthetics. So the first time is always the best time in the eyelid.
And I think another thing that's important is that the patient has to be very calm, especially if there's a pediatric patient. Please do not attempt eyelid suturing without anesthesia, because you have sharp instruments in your hands and the globe is right there. So it's very, very important that in adults, you can suture something like this under local when the patient is cooperative, but in children, even very small lacerations on the eyelid must be done under sedation or anesthesia.
Absolutely. I think even in adults, a lot of adults get very nervous when they have injuries around the eyelid, especially if there is a composite injury. I probably better to just do it under anesthesia.
Yeah.
So let's go to the next slide. The nose. The nose is the most important part of the face, primarily because like we spoke about other things, the vision or our eye always catches the nose. The nose is different to other areas because the nose is made up of not only cartilage, it's made up of bone, it's made up of skin. It's a composite structure, and it forms an airway which allows you to breathe internally. So it has a functional and an aesthetic component, which means you have to make sure that the bones, whether there are any fractures. So with a CT scan, you do a CT scan and check if the bones are fractured. If they are, you most probably will have to fix it because they'll either cause an external deviation or cause some airway issues. If there is a septal hematoma, which means the main center part of the nose, which is seen, because of the injury itself, they can develop a hematoma or a blood clot, and because of that, the space in the center of the nose increases, and because of that, the airway, which means your ability to breathe, decreases. And if the hematoma kind of organizes over a period of time, it's very difficult to kind of fix that kind of septal hematoma. So these are the things that have to be seen immediately. You have to see then if there are any loss of skin on the nose itself. Like we spoke about earlier, the face is relatively forgiving, but because of the convexity of the nose, especially in adults, the scars might not heal well in the upper part of the nose. So the skin of the dorsum, of the caudal dorsum, tip and ala are adherent and might not get a primary closure because there is some loss of tissue. What do you think we can do to kind of fix that if you're not able to primarily close it?
I think complicated injuries on the nose generally need some kind of
Yes.
reconstruction. We may need composite grafts taken from the ear. Many times we use full thickness skin grafts on the nose. I think nose injuries are more common in dog bites,
Yes.
isn't it?
Yes.
We see a lot of dog bites with bad nasal injuries. And in our practice, I think we have used a lot of full thickness skin grafts and composite grafts for nose reconstruction. Nose is also one thing that initially is left to heal by secondary intention. And in some cases, it is prudent to do that. If there are small gaps in the ala, it's better to leave it at that point, allow it to heal. It definitely needs a reconstruction, but it's much easier to evaluate how much of reconstruction is needed and choose the right flap when it's done at a second stage. So in a little bit complicated nose injury, some of them can be allowed to heal secondarily and dealt with later.
Yes, absolutely. So when we are talking about what she means is the ala might be lifted slightly up because of the injury, but because of if we aggressively try to do something, we might not get the best possible result. So most of these cases, you kind of try to fix it with some kind of procedure that can be done in the meantime, but allows us to do something later as well. So the nose is probably one of the most important things when we talk about the face, primarily because, like I said, it involves both the cosmetic and functional issues here, where if the breathing is not corrected immediately, then you kind of going to have problems in the future. And most of them do come for maybe like a septorhinoplasty later in life. I think that is one of those things that needs to be looked at. So let's go to the next slide. All right, let's go to the next slide. Okay, so till they kind of get that, we were talking about the landmarks in the face. So it's very important on the face that you recreate those landmarks to kind of get continuity. Probably we will also be talking about the, say, the cheek now, where there are two important functional things that have to be seen when we are talking about the cheek. We already spoke about soft tissue reconstruction of the face, which means any part of the face can be corrected in any way. But when we're looking at the cheek, what are the two most important things that we need to look at?
So two important things. One is the parotid duct and the facial nerve. So any deeper injuries on the cheek, these can be injured. And as you know, both are very, very important. If a parotid duct is left or not recognized an injury, it can lead to xylocele formation, meaning saliva can accumulate in the gland and lead to a visible swelling. So though it may not be possible to repair this every time, it it is good to have an idea about whether an injury is present. If a silocele develops, then serial aspirations with pressure should generally help in controlling it. Coming to facial nerve, was very, very important. But most of the times with superficial injuries, luckily the facial nerve does not get injured. But if there is a deep enough injury, then ideally you have to examine under a proper magnification. I think with naked eyes, it is impossible to check whether or to look for the cuttings of the nerve. You must go into the surgery having an idea whether the nerve is cut or not. You cannot go into surgery and then look for it. So clinical examination before you start the procedure is very, very important. And also before you give any local anesthesia, completing the physical examination is very important. So you look for different functions of the face. As I said, deviation of the corner of the mouth, whether the patient is able to blow both the cheeks equally, whether he's able to tightly shut both the eyes equally, and whether the forehead wrinkles are equal on both the sides. So if all this is fine before you start the procedure, you can be pretty sure that, okay, the facial nerve might not be cut. But in case you see that there is a clear-cut injury or a clear-cut manifestation of it, then it has to be managed by somebody who has microsurgical skills. So ideally, it has to be even under loop magnification. Sometimes it might be very difficult to find the nerve, and the ideal thing to do is to use a surgical microscope, where we explore, look for ends of the nerve, and then use very fine sutures to do a primary neurography. If this is missed, and if the patient develops facial nerve palsy, it is much, much more difficult to correct it later. The procedures are much more complex, and you don't get near total results.
Absolutely.
So this is something that should not be missed and should be referred to an appropriate specialist.
Absolutely. So functionally, it's very important to look at the cheek with the parotid duct and the facial nerve. So let's go to the next slide. The ears, most commonly, what do we see in the ear? You see in injuries related to in sportsmen, in wrestlers, in people who have had a fight and suddenly have had a hematoma in the ear. Why are these hematomas very important to be drained? Because then if they organize, then you get something called a cauliflower ear. If you see a lot of the wrestlers, a lot of the boxers, a lot of people who are in that particular line of work will always have a kind of, because of micro trauma to the ear, develop something called a auricular hematoma, auricular or a cauliflower ear. Whereas in a person who's not in that particular field, if you see a hematoma in that particular part, it is very important that you release the hematoma, you evacuate the blood in that particular area, and give a good pressure dressing. A pressure dressing is very important, because then it contours to the earlier shape of the ear, and hence doesn't cause any permanent deformity. Also, when it comes to lacerations, the ear is a very has complex anatomy in terms of this. So remembering how to create continuity in terms of landmarks is very important, so that you get a complete normal anatomy and visualization of the ears. Cartilage sutures are generally not needed. Partial amputations with a wide pedicle has a good prognosis with conservative debridement and repair. This is quite commonly seen.
Yeah.
Sometimes the ear kind of is just hanging. You just place it back, fix it in place, and most of the time it does
Most of
heal.
the time it survives. Yeah.
Yes, it survives. Let's go to the next slide. Next slide, please. Anything else you want to add with the ears?
I think the lobule injuries are very common.
Yes.
It could be because of a fight or altercation where somebody pulls off somebody's earrings. We see a lot of those cases. So in those cases, it's mainly giving a very good cosmetic outcome, where the continuity of the lobule, again, it should look like a perfect semicircle again, and there should be no step-offs. And the patient should be able to wear a proper earring again. So it's a simple repair, but it should be done with proper care to get the landmarks right.
Yes, that is why we keep reiterating the importance of landmarks, the importance of um, continuity of any part of the face, especially when it comes to like the lobule, which is a semicircle, which is like the ala of the nose, which is also, it's very important to get those landmarks right. So, and probably the most important landmark is actually the white roll alignment in the lip. The lip, as you see, the upper edge of the lip has something called a white roll or a white line that goes through the lip. So what happens when there is a cut on the lip? Is there a functional deformity or purely a cosmetic deformity?
So the lip basically has three structures: the skin, the muscle, and the mucosa internally. And the orbicularis oris muscle is completely responsible for the competence of the mouth. So when there is a full thickness cut of the lip, which are very, very common, it's very important to do a proper 3-layered closure. So, but again, the continuity of the vermilion border and the white roll are the most important things you need to look for. So again, the first stitch should always be at the white roll and the vermilion border, and then you do rest of the repair. If you start and do everything and come to this in the end, you will never get the alignment right. And also the repair of the muzzle is very, very important. A lot of people just miss that. It is difficult to visualize it because it is very much adherent to the mucosa and skin. So you must take enough care to separate out the muzzle layer from the skin and mucosa, a few millimeters on each side, and take strong sutures through it. If there is dehiscence of this, or if it is not repaired, there will always be a big dent over there, especially when the patient talks, smiles. It will be very, very obvious and looks very unsightly. Again, it is difficult to repair at a later stage. So the muzzle repair is of paramount importance, along with getting the white roll right.
Absolutely. Well said. Next slide, please. So the now to kind of encompass everything, it is very important to understand where we started from when it came to facial trauma. Remember your ABCs. Remember how to assess the face when it comes to you. Remember to see the most important things like blood in the mouth, conscious level of the patient, if there are any loose missing teeth, any fractures in the face, vision, how is the vision of the patient, occlusion of the jaw. These are the most important things that you need to see. And then as you described, you look at injuries. So first you see fractures, you fix the fracture first, and then you look at the different injuries of the face. And each part we divided into different parts so that you understand each part is as important as the other. Because when you look at yourself, or when someone else looks at you, it is very easy to make out any even small deformity that happens on the face. So it's very important to take this very seriously, to understand how to assess trauma in the face, and to reconstruct the face in a way that gives a long-term aesthetic result to the patient, and psychologically gives them confidence to kind of get back into society and get back into work. Thank you everyone for joining us. Thank you, Dr. Keerthana. Is there anything else you may want to add regarding our talk today?
I think the takeaway points would be, if you're a surgeon dealing with facial injuries, you must use very fine instruments, which is very, very important. Tissue handling is extremely important in deciding how your scar looks later. So right instruments, right suture materials, and right technique. All three must be there to get a good scar.
Yes. And remember, where possible, do it in the operation theater.
Yes.
Do
Under
it
proper anesthesia.
Anesthesia, good
Asepsis.
anesthesia, good light, good instruments, someone to help you, like a good nurse or an assistant. All these are very important to make, like we said, to make yourself comfortable so that you can give a good result to your patient. It's only when you are comfortable you can give someone else a good result. So thank you for joining us today, and hopefully we can talk a little more about how specifically suturing of the face can be done. Hopefully we have more sessions on this, and we have a little more advanced training on this kind of trauma of the face. I thank Global Health Academy and Dr. Jayashree for introducing us, Global Health Academy for giving us the platform, and Dr. Kirtana, as always, we work together. So this was something we also wanted to do together. Thank you so much and have a good day.
Thank you.
Thank you so much, Doctor. It was a great webinar.
Thank you.